people don't know about this, and they don't know that that a patient with temporomandibular disorder, for instance, it affects every aspect of their life because the pain is in their face. It's not like they can put their foot up and rest until their sprained ankle gets better, and they need these joints for survival.
Hello, everyone. Welcome back to the channel, or welcome to the channel if you're new here. We have this wonderful guest in front of us today. We have Dr. Suzie Bergman. She is a dentist, an author, and a huge advocate for whole person health. So we'll dive into a little bit more about what that means. But before we do, Suzie, welcome to the channel.
Thank you so much for having me, Jillian.
And thank you for being here. And for anybody who has not yet met you, may you please tell us a little bit more about yourself?
Sure. So I am a general dentist. I practice in Vancouver, Washington with my husband. We have a private practice, and I also lecture and travel internationally on behalf of patients with temporomandibular disorders and orofacial pain. I work with a foundation in India that teaches oral surgeons how to treat patients without surgery, which is a novel idea. And I participate in advocacy and infrastructure for TMD patients.
And I love everything that you are putting out. I know we met on social media where there's a strong advocacy effort in talking about this need for the integration of medicine, dentistry, behavioral health, and really that whole person health. And I love that you teach surgeons. As somebody, I was in oral surgery for 3 years, and we always learn that surgery is the absolute last resort when it comes to anything in the TMJ. And I understand you have a little bit of a personal story that brought you to interest in that topic. Can you share a little bit more about that?
Sure. So I survived a really crazy accident when I was 19 years old. My friend accidentally ran me over with her car. It threw me over a hill. The car then came down on top of me, and my poor friend thought she had killed me. But when I went to the emergency room, we weren't really focused on my jaw. So it wasn't until several years later that I realized how much damage had been done by that accident. And I spent about 30 years trying to avoid what eventually happened in 2019, that I got titanium jaw joints. So I say I'm bionic now, but I'm actually feeling so much better than I ever have as an adult. But I am a chronic pain patient, so that's part of the reason that I really feel for my patients and try to help them um, avoid surgery if they can. But the real goal is that we teach these patients how to manage their pain.
And that's it's an important perspective. And for people that don't know, oral facial pain is now a dental specialty, as well as oral medicine. We learned about oral facial pain, and oral facial pain is often a topic where people are like, if they're not invested in learning about oral facial pain, they can kind of have some standoffness about it because it is complex. Pain is a very subjective experience, and often that pain that the patient experiences isn't corresponding with the anatomical changes in their jaw. And like there can be MRIs where the joint is so bad, but the patient's not having pain, or the MRI looks great and it's severely painful. And for you to have that very personal understanding and that empathy it's so important in helping those patients to feel heard and to make sure you listen so that you're not missing anything.
I agree. It is a very challenging specialty, and it's one that we can't do in silo. So, we need to work with our counterparts in medicine and the ancillary service providers, such as physical therapists and speech pathologists and other ancillary providers, because patients need that whole person support, and emotional well-being is usually affected adversely by being constantly in pain. So it's important that mental health is also part of the health care that we provide for our patients.
Yeah, and as sometimes there's this medical gaslighting when it comes to chronic pain, where people think, oh, it's either psychological, right? And we know, as you just said, chronic pain can impact you psychologically. You're maybe not sleeping, you have a lot of heightened anxiety because you're in chronic pain, and it can lead to reduced quality of life and depression. But then sometimes because we can't see pain, right, people will oftentimes just say, oh, that must all be in your head. And it's some feedback that we've received, that when a patient finally feels heard for the first time, and they're not told it's all just in your head, and referred to people who just kind of keep getting punted around, how so important it is to truly listen to the what that patient's going happening to them, and understand that the impacts of chronic pain can exacerbate the anxiety and depression. So I really like how you frame that it can have an impact psychologically, and not it's all in your head, right?
That's right. And so many patients hear that. I actually met a lady one time. The first thing she said to me was, "We're not crazy, are we?" And, patients, I have unfortunately some heartbreaking stories of things that patients have been told by medical providers that have actually caused them to take their lives. And it's not like it's only happened once. What's unfortunate is that it's people don't know about this, and they don't know that a patient with temporomandibular disorder, for instance, it affects every aspect of their life because the pain is in their face. It's not like they can put their foot up and rest until their sprained ankle gets better, and they need these joints for survival. So they need them for speaking and eating and showing emotion. And so when I see a patient for the first time, I try to make it as easy for them to tell me their story, and I don't rush them through it. I have a box of tissues right beside the chair, and I let them tell me how this has affected them and their relationships and their ability to work or to care for their children. And just knowing that someone cares and understands gives that person so much hope that they don't feel like this is just what they are going to spend the rest of their life feeling. Once we help people with down regulating their nervous system so that they're not in fight or flight, we have a much better chance of being able to help them manage the pain that they're experiencing.
And you highlighted it so well. When it comes to that anxiety, we know that higher anxiety lowers your pain threshold, so that
Mhm.
you're experiencing that pain at a heightened degree. And
Mhm.
also, I value that comment you made about hope. As someone who has experienced suicidal ideation, and as part of my own journey, hope is what provides us the opportunity to keep holding on. And without it, on top of feeling the distress of pain and not feeling heard, and often not being validated, it is our role as people that are clinicians and people who are in the industry of helping others and to help heal, that listening is something that in our structure with the 15-minute appointments, a lot of times people don't feel that they have the opportunity to do. But for yourself, I know that you have a private practice model. So I'm curious how you make sure that you have the time and space for the patients to be heard.
So, a lot of times I will see a patient in the neurosurgery department or Oregon Health Science University, which is the medical school closest to me. And these patients have usually been misdiagnosed. So they may come in there thinking that they have trigeminal neuralgia or some kind of neurological disorder. And once I've examined them, we schedule an appointment in my practice. Um, where we do a comprehensive exam and I give them plenty of time. So we schedule an hour and a half for those patients. And often, if it's a complex case, then they might be seen in another practice that I founded recently called Integrative Therapeutics. And that practice has medical, dental, and behavioral health support for the patient. So I kind of think of myself as a quarterback. I try to help get these patients to the providers that they need so that we can form a team and we can be communicating about the patient's progress and what each of us can do um, together for the patient so that it's not constantly the patient feeling like they have to come to me and say, well, I went to this person and they told me this, and I went to this other person, but they didn't agree. It gets very confusing for the patient. So they need to see a team that's working with the biopsychosocial model of health for whole person well-being.
And a lot of what you demonstrated about the impacts of TMD, I think about as a head and neck cancer researcher about the quality of life impacts from radiation treatment and how I was reading in the literature that patients with head and neck cancer have a 2 times risk compared to other patients with cancer at taking their own life and a 3 times risk compared to the general public. And of course, the question is why, but everything that's happening to the head and neck, it correlates with oral facial pain. Patients experiencing the oral facial pain it's affecting everything, the psychosocial aspects. And in considering aspects of where I work in a cancer institution where we do have everybody in a centralized location, and how much more efficient that is in helping to make sure that patients don't get lost through the cracks. And then talking to private practice radiation oncologists who are getting referrals from ENT, and then those referrals aren't being sent to the dentist. And so our structure is that if a patient's diagnosed with head and neck cancer, they get sent to everybody that they need before radiation treatment. So it's kind of an established workflow. But when you're out in the community, if you're not at an academic center or at an institution where that's the norm, how challenging it is. And even if you're in an urban setting, it's challenging. But if you're in a more rural setting, it's even more challenging. And so if we could paint the picture, and we can talk, of course, about the current gaps, but if you could paint a picture for me at kind of the ideal integration of medical, dental, and behavioral, what would that look like to you?
So what I would love is for patients to have an appointment that might be a morning or an afternoon where they come to one location. Now we're taking away some of their challenges. They can park in one parking spot, have a babysitter if they need it for one morning or afternoon, and see all of the providers in the same facility where the providers are actually having rounds and discussing each case. For example, they could see the primary care physician or a nurse practitioner first. And then when they need to be seen by an orofacial pain specialist or a dentist who focuses on those disorders, that would be a history and intake and initial exam. And after that appointment, they would be seen by a physical therapist or maybe a speech therapist or an oral myologist if they're having difficulties with chewing and swallowing. Then they could see a nutritionist so they could talk about what they can eat that's anti-inflammatory and not just what they can eat that's soft. And then they would see a behavioral health specialist to talk about how this is affecting their relationships and their sleep, their mood, their desire to continue. I've had so many patients tell me that they just don't want to feel like this anymore. And after, I had one patient tell me that I was the 27th provider that he had seen, and he was angry, and rightfully, angry. He said, what are you going to tell me? Because everyone else just shrugs their shoulders and says, I don't know what this is, or I don't know what to do about it.
Yeah, and I feel like there's so many things that come to mind that were hurtling, right? Because having that patient go into one center and having all the notes in one location, as you said, so they don't have to repeat themselves, and so that you can go back and you can get all the puzzle pieces that you need to put it together. Because in the silo, so for patients, they may or may not be aware. So we'll just kind of paint the picture, right? There's the EHR, so the electronic health record that different institutions will have, and there's EMRs, like electronic medical record, that's usually, it's a terminology that sometimes is used together, but it just means it's for, one location, could be an external clinic. And then in dentistry, there's electronic dental records, which are formulated so that we could do all the dental charting. But because the vendors who create these softwares are a company, they don't want everyone to come together, right? They want to keep the competition high. And the detriment that it does is that it keeps all the patient's information separate. So, like you said, they're repeating themselves. They may have thought they told you something and they hadn't. You might have had an imaging at one center and they may or may not talk. There are some now electronic health records that they have a way of grabbing some information from other hospitals. But even at the VA where I go for the military members, sometimes the information you have from other VAs aren't even centrally located. And then, of course, we have the differences in the insurances, which complicate our ability to fully integrate without having some of those administrative obstacles from the clinical standpoint.
That's so true. And, when you mentioned the VA, they're actually doing a better job than a lot of other places, but it still needs improvement. And a lot of times, what happens from the patient's point of view is that it's so confusing to them. They're going to get a super bill, or is my insurance going to cover this? And they've already, used a lot of their benefits. And so sometimes they choose not to go forward with treatment, or even like have their physical therapy appointments because they say, my insurance isn't covering this anymore. I can't pay out of pocket. And I don't want to go on disability. The choices are really big, impactful, life-changing choices sometimes. And so I honestly believe that as long as we do this fee for service thing in dentistry, it's not going to help these types of patients, which is also another reason that a lot of dentists don't get involved in treating patients with these types of disorders, because they don't know how to make it it doesn't serve them from a practice ownership's point of view, because they have to be able to produce so much to cover their overhead. So the patients are suffering, and even some of the dentists who would like to help them feel like they don't see a way to that it's practical. And then the other big problem is that a lot of this was not taught in dental schools. So now that we have orofacial pain as a specialty, it's getting better, but we only have about a dozen orofacial pain programs around the country. And 10% of Americans, that's kind of a mid-range figure, 10% have some form of temporomandibular disorder. So we have 35 million people who have only these few handful of providers that feel like they know how to help them. And unfortunately, a lot of the treatments that were done in the 80s and 90s have now been shown to not be evidence-based. So we have providers who think that they're helping their patients, but they're doing something that isn't actually improving and could potentially be harmful. And there's so much work to be done that we really need to get all the stakeholders involved and call them to action and say, this is an urgent problem. Cancer research is, it's widely understood that people with cancer need research. And it's really lagging for patients with TMD. We have a paltry amount of research on the topic. And one of the problems is that this is the only joint in the body that isn't treated by an orthopedist. And it's also the only joint in the body where both sides are working together. So whatever happens to one side is affecting the other side. Um, yeah, so lots of things that we need to work on.
Yes, and it seems like, oh my gosh, when problems are too big, we can develop this learned helplessness, right? If we think we're going to tackle the problem and we shoot too far up, meaning that we think that we need to solve everything at one time, but we know that sustainable change comes from taking those small steps. So we're creating awareness today, but as the small steps of solutions, what would you say are the next best steps or next steps that we should consider towards a solution?
One of the things that I think can happen right away is that providers who are interested in caring for patients with these types of disorders educate themselves. Um, if they look for uh, courses that are evidence-based and not just something where they're going to tell you, hey, I'm going to teach this to you in a weekend and you can go back and take care of everything. Those are not the types of courses that they need. But if providers could educate themselves, and if we could give patients tools to help them kind of advocate for themselves. And I actually have an idea that I've been working on for a while that would be a digital health solution to kind of bring that assistance to the patient in the form of an app, possibly, or maybe even a web-based product, so that the patients and the providers are on the same page. I think that once we start doing that and the providers kind of look outside the box a little bit and say, hey, if my patient needs this referral, the best thing that I can do is communicate with the person I'm referring to so that we are working together for the benefit of our patient.
I love that. I just went to a conversation. I think they call it a symposium. It's every Wednesday morning now, put out, I think, by Mass General, and it's about headaches and pain. You know what I'm
Yeah, I
talking
attend
about?
that too.
Yeah, and they
It's
just, yeah, yeah, please.
I was gonna say it's 5 a.m. for me on the
Oh,
West Coast, so
that's right, it is.
so sometimes I'm barely awake, but I'm just saying I need to hear this. I want to listen. Yeah, it's
Yeah,
great.
so it's important, as you were saying, because the evidence base, even if we were following what was evidence based back when I was in dental school, the most recent discussion was like poo-pooing that, right? It's no longer evidence based, or the evidence is in the contrary now. So you're even the clinicians who are demonstrating the evidence and they are following the practices that they learned several years ago, and I graduated 10 years ago, and things have already been modified. As you were saying, the research funding wasn't necessarily there, right, in TMD necessarily. So then when people do take the time and they try to validate previously held beliefs, and they can either say, yeah, this is still true, or I'm not exactly seeing the same things that we thought once upon a time. I think we need to reconsider either the
Mhm.
pathophysiology or the approach to care for oral facial pain. I clenched and grind quite a lot. And when I first got a night guard, it was in dental school, and it was the NTI that only covers here. And
Uh-huh.
I would only work like for 2 days. And then my school was like, it wasn't from anyone trained at my school. It's a different philosophy, which, not saying anything negative about that, because that could be deprogramming for a short period of time. It might have
Mhm.
its role, but for me, it did not. And of course, this is for educational purposes only. But I quickly learned, like, oh, that could have done more harm than good. So
Right.
just like you said, don't do if you are a clinician that's listening to this, please do not do a short course and think that you have the information you need. Also, don't absorb and accept everything that you learn. Make sure that you do your own research and that you confirm through the literature that you do believe that that theory is true. Weigh the pros and the cons so you know the risks, because there are risks with every intervention or not intervening for patients, and especially when it comes to what you said about surgery, and you have had the experience with having the surgery yourself. But make sure that that is the last resort, and that that patient absolutely needs, or they have some anatomical reason why it might be considered sooner than later
Yeah,
for some patients.
definitely.
So you're telling me a little bit more about breathe works. Can you kind of go into that a little bit more?
Yeah, so we work with our patients on identifying the type of breathing that they are doing, which for most people in pain is going to be shallow chest breathing. That's just our natural response when we feel threatened, when we're in a state of pain. So what ends up happening is that we breathe more with our accessory neck muscles than we do with the ones that are meant for respiration. And when we teach patients to do diaphragmatic breathing and to really work on getting respirations that aren't shallow, it helps again with reducing their pain symptoms. And then they feel a sense of control because they have something at their fingertips that they can do to help manage their pain. So, breathing is one of our favorite things to work on.
I think that's so important for anyone that comes in with dental anxiety as well, or just
Yes.
everyday anxiety. What I need, and if anyone's listening, I would check in to see how are you breathing right now? Because, and not so much the neck for, when if we're not in pain, but the shallow breaths, like just not even getting the oxygen. I tend to realize that I almost hold my breath when I'm ruminating and I'm so anxious. And then how much that exacerbates your anxiety until you just pause and take a good deep breath in.
Yeah, and actually there's something called a calm strip that you can put on your phone or your keychain that gives you a visual. So you can practice box breathing by tracing the box with your finger and just doing the four seconds of inspiration and then holding for 4 seconds, exhaling for 4 seconds and holding again. And that box breathing is really helpful for people with anxiety.
Oh, nice. So it's an app, you said?
Well, there is an app
Mm.
called, I think the app is called Breathe Plus, but now there's just this little thing that I ordered online called a Calm Strip.
Calm strip.
And it's adhesive, so you can just stick
Nice.
it on anything, and it gives you a nice visual to help you remember about your breathing.
Awesome. Well, I'm definitely going to include that in the show notes. And I want to hear people, how are you breathing right now? I'm really curious because I often think, I know I'm not the only one who's barely taking any inspirations in and really learning how to exhale. And a lot of times people talk about the 4-7-8 breathing, but holding our breath for 7 seconds when we're starting is a little long. So I
Yeah,
like that you broke it down to 4 seconds each. I think that's a good start.
yeah,
All right.
definitely.
Thank you for sharing that.
I have a quote I would love to share with you that
Yes.
kind of encompasses all that we've been talking about. My mentor shared it with me when I first started getting really serious about treating chronic pain patients. And it says, natural law did not divide us into three groups: medical, dental, and behavioral. If society chose these divisions for the purpose of healthcare delivery, then each of us bears a special responsibility to be sufficiently informed about the others so that integrative total health care can be an achievable goal. And that's kind of the quote that I think of every day when I work on this interprofessional education and integration kind of um, approach, and that I have seen people who have are like-minded have been able to make, good strides in helping us to bridge the gaps and remove some of the silos that are present right now. So
Oh, that's a fantastic quote. And it comes to thinking about the responsibility of when we're in education, right? To have the integrative educational discussions we had in medical school. They brought in the nurses and we were having the same scenarios and you're seeing everybody's different perspectives. And then when it comes to tumor board, if a patient's having a treatment for cancer, you have all these different specialties collaborating, and what you learn is we all have different hats on, different perspectives, so we're looking at it from all these different angles in order to come to a consensus about what's the next best step for treatment for this patient. And you just captured it so exquisitely there about why this is so important, and it's fixable, right? It's a problem we created, and it's a problem that we can be part of the solution to solve.
Definitely. I agree.
Well, thank you so much for sharing that and for the discussion today. Are there any last words you want to leave with the audience?
I would love to hear from anyone who would like to reach out to me for more information. I do have a pretty good network of providers around the country. So sometimes people will ask me, do you know anyone that I could see on the East Coast or so on? And so I can be reached at DR for doctor, Suzie, Suzie, Bergman, Bergman, at gmail.com. And my website is Dentistry on Officers Row.
I really appreciated you being here. And of course, for the audience, if you have questions, and also we were talking before we stepped on the record button about different communities that do have these models that combine medicine, dentistries, behavioral health. If you are part of a system that's working or that is leaning in that direction and you want to share it with us, this is where it happens, where we start these conversations. We see places that are doing something that is different than the status quo, that's giving the benefits that you nicely said here. It's for both the patients having that one-stop shop, making sure that they don't have to repeat themselves, making sure that they can have hope, making sure that they don't get lost in the system. And of course, for the collaboration between all the healthcare professionals. So if you have the solutions, if you have suggestions, if you have further comments, we would love this to be a very interactive discussion, and we can't wait to hear from you.